Thank you for joining today's conference call, The Opioid Epidemic, Facts, Trends, and Prosecutor-Led Community Responses, hosted by the Office of National Drug Control Policy and the National District Attorneys Association. We will begin shortly with a webinar introduction by Mary Lou Leary, Deputy Director, Office of State, Local, and Tribal Affairs, ONDCP. Joining Deputy Director Leary on the line today are ONDCP Director Michael Botticelli, ONDCP Associate Director for Research and Data Analysis, Dr. Terry Zobeck, District Attorney Michael Morrissey from Norfolk County, Massachusetts, and Prosecutor Joseph Coronato from Ocean County, New Jersey. And now, without further ado, I am pleased to introduce Deputy Director Mary Lou Leary from ONDCP.
Thank you. And thanks to all of you for joining us today when we discuss the nation's opioid crisis and the very important role that district attorneys can play in helping to address this issue. As you heard, our speakers today include Michael Botticelli, who's the director at ONDCP, Dr. Terry Zobeck, Research and Data Analysis Director, Prosecutor Joseph Coronato from Ocean County, New Jersey, and the District Attorney from Norfolk County, Massachusetts, Michael Morrissey. Also joining us is Kay Chopard-Cohen. Kay is the Executive Director of the National District Attorneys Association, so we're glad you could be with us in person, Kay. We'll hear all the presentations, and then we'll open the lines for questions. So let's get started. Slide, please. ONDCP is a component of the Executive Office of the President. Was created by the Anti-Drug Abuse Act of 1988 to advise the President on drug policy issues. Our office is responsible for producing the administration's National Drug Control Strategy, which is the federal government's primary blueprint for drug policy. We're also responsible for developing a budget for strategy implementation, and we oversee the interagency implementation. So this administration's science-based plan to reform drug policy has 4 goals. 1, prevent drug use before it ever begins through education. 2, expand access to treatment for Americans who are struggling with substance use disorders. 3, reform our criminal justice system. And 4, support Americans in recovery. The administration works on a variety of issues involving drug policy. The opioid epidemic facing our country factors into every facet of our work, and with very good reason. As you know, we're in the midst of an emergency situation. Slide. In 1999, there was 1 overdose every 30 minutes. Slide. In 2013, there was a drug overdose death every 12 minutes. So at this rate, in the amount of time that we spend on this webinar, 5 more people in this country will die from a drug overdose. This is a really alarming trend that we're all facing in our communities, and it's the reason why we're here today. Slide. Let me introduce Michael Botticelli, who was sworn in as the director of ONDCP in February of 2015. He used to serve as the acting director and the deputy director of ONDCP, joining the office in November of 2012. He has more than 2 decades of experience supporting Americans who've been affected by substance use disorders. Prior to ONDCP, he served as the director of the Bureau of Substance Abuse Services at the Massachusetts Department of Public Health. He has brought with him the perspective that substance use disorders are preventable and treatable diseases, and he has greatly expanded prevention, treatment, and recovery initiatives across the country. We're very fortunate to have him leading this country's drug policy efforts. Director Botticelli, and turn it over to you.
Okay. Thank you, Mary Lou, and it's a pleasure to speak with all of you today. As leaders in your community, you know the devastating impact opioid use is having on families and communities across the country. This epidemic has no boundaries. Age, gender, economic status does not matter. Whether one lives in a rural, suburban, or urban jurisdiction does not matter. What does matter, however, is that it takes all of us to overcome this epidemic. We must work with all sectors of the community, youth, parents, faith-based organizations, with government and private agencies, health and medical professions, law enforcement, education, and social services. and with the private sector as well, including pharmacies and the pharmaceutical industry. You are in a position to bring all of these stakeholders together to solve this problem. When science began to study addictive behavior in the 1930s, people with substance use disorders were thought to be morally flawed, lack willpower. Those views shaped society's response to substance use disorders, treating them as a moral failing rather than a health problem, which led to an emphasis on punitive rather than preventative or therapeutic responses. Even now, discussions of substance use disorders are too often relegated to the shadows and are still steeped in stigma and misunderstanding. Today, our nation's response to substance use disorders have begun to change. Groundbreaking discoveries about the brain have revolutionized our understanding of drug addiction, enabling us to respond more effectively to the problem. The time has come to treat substance use disorders as a disease. Next slide, please. Reducing opioid misuse and overdose is a top priority for this administration. In 2013, there were more than 16,000 overdose deaths in this country involving prescription pain relievers and over 8,000 involving heroin. In the same period, deaths from motor vehicle accidents have decreased while drug poisonings, particularly those involving heroin, continue to rise. We are truly in the middle of a crisis, and we do not have time to wait to bring about change. Coordinated efforts across public health and safety are essential. Next slide, please. In 2011, the administration developed the Prescription Drug Abuse Prevention Plan, which calls on individuals and organizations at federal, state, and local levels to educate people on prescription painkiller misuse and abuse, including prescribers and the public. It monitors prescription drugs being written and filled, to offer opportunities to safely dispose of unused or unneeded medication, and to reduce the number of illegal and unethical prescribing practices. With the alarming uptake of overdoses involving heroin, we are redoubling our efforts. Next slide, please. Opioid overdoses strike every community in this country, but they can be reversed if an antidote is administered in time. Naloxone is that antidote. This is a quick-acting prescription medication that rapidly blocks the effects of opioids and quickly restores breathing. Naloxone can be easily administered. It generally works within 5 minutes and wears off within 30 to 90 minutes. Over the past year, many law enforcement agencies have begun to administer naloxone to individuals undergoing an overdose. When officers trained in the use of naloxone recognize the signs of an overdose, their ability to administer the drug quickly can mean the difference between life and death. In the past, it was frustrating for law enforcement officers to stand by watching someone overdose. Now they can do something about it. Now they can save lives. Naloxone is a valuable tool, but is just one part of an effective overdose prevention plan. Prior to 2012, just 6 states had laws that expanded access to naloxone or limited criminal liability for those who administer it to someone who appeared to be overdosing. Today, however, 35 states and the District of Columbia have passed laws that offer criminal and or civil liability protections to lay people or first responders who administer naloxone. 24 states have passed laws that offer criminal and or civil liability protection for prescribing or distributing naloxone, and 33 states have passed laws allowing naloxone distribution to third-party or first responders via direct prescription or standing order. Additionally, 25 states have enacted so-called Good Samaritan laws to help those in danger of overdosing so they can obtain the help that they need. These laws remove the fear that someone may be arrested at the site of an overdose. Good Samaritan laws do not cover all drug charges, and they are not a get-out-of-jail-free card. But the goal is to save lives, and getting help quickly can do just that. Education, naloxone, and new laws are all essential parts of a comprehensive overdose prevention plan. However, we must think about what happens next for a person with an opioid use disorder. Any successful plan must also include linkages to treatment, and developing a mechanism for these linkages is critical to helping individuals with a substance use disorder. Another important element is medication-assisted treatment, which is the standard of care for people with opioid use disorders. Introducing FDA-approved medications to people during the course of their treatment can make overdose referral unnecessary and help them manage and overcome their disorder. It is really heartening to know that a number of district attorneys, including Joe Coronato in Ocean County, New Jersey, and Michael Morrissey in Norfolk County, and John Blodgett in Essex County, Massachusetts, are advocating for naloxone use by police and first responders. As leaders in your community, your support speaks volumes about the importance of a full community response, including prevention, linkages to treatment, prescription drug take-back days, and the adoption of Good Samaritan laws. Opioids are a serious problem, and I encourage you to get engaged in overdose prevention. Thank you for your time.
Thank you, Director Botticelli. Next, we're going to hear from Dr. Terry Zobeck, Associate Director for Research and Data Analysis at ONDCP.
Thank you, Mary Lou. It's a pleasure to be here today. I'll be talking about heroin, where is it coming from, and what are some of the serious consequences of its use. Next slide, please. There are 4 major opium poppy growing regions in the world. Southeast Asia, which is the Golden Triangle, Thailand, Burma, and Laos. This is a major area that produced heroin that was consumed in the United States, less so now. Southwest Asia, specifically Afghanistan. This is the world's largest producer of opium poppy and heroin. And then Colombia, which in the 90s the Colombian drug trafficking organizations began to cultivate the poppy there and provide quite a bit of the heroin consumed in the United States, in the eastern United States. And then Mexico, which has traditionally been a source for heroin consumed in the United States, and in recent years has become the dominant source for heroin consumed in the United States. Next slide. And this slide shows heroin seizures domestically by either federal agencies or state and local agencies. And you can see that in 2013 there were 6,000 kilograms, about 3 metric tons of heroin seized in the United States, and this is up sharply since 2007. Excuse me. And most of this increase has been from seizures at the southwest border, indicating that this is heroin coming from Mexico. Heroin from other sources usually come in through commercial air travel and internal body carries. The heroin coming up from Mexico is packaged in hidden vehicles and on persons. Next slide, please. This is an estimate of the number of lifetime heroin users. This comes from a survey that the federal government does called the National Survey on Drug Use and Health. And there's 3 segments here that reflect changes in the methodology. So the increases aren't all due to actual increases in use. Some of those are methodological artifacts. The most important thing here is the trend since the 2000s. It was fairly stable from 2002 through about 2008 or 9. But you see this sharp jump through 2012. This is very alarming that we've seen this increase in the number of people saying that they had used heroin at one point in their lives. Next slide, please. And we know that heroin use is inextricably linked with the non-medical use of prescription opioids, pain relievers. This slide shows past year non-medical users on the left-hand side in the yellow at about 11 million users in 2013. The line below, read that on the scale to the right, that's heroin users at about 700,000 in 2013. So there's quite a few more non-medical users of prescription opioids than there are heroin users. Next slide, please. But research tells us in recent years that it's those non-medical users of prescription opioids that are feeding the heroin market. The large circle represents initiates or new users of non-medical use of prescription pain relievers. Over the past 5 years from the time this study was done about 2 years ago, there were about 10 million people that had begun using prescription pain relievers non-medically. The smaller red circle are the number of heroin initiates over that same period, about 500,000, so about 100,000 per year. And we know from the survey that 80% of those recent heroin initiates the first opioid they ever used in their life was a prescription pain reliever. This is completely different from what we saw in the past. You go back 20 years and you ask current heroin users, what was the first opioid you used? It was going to be heroin. And so while it's 80% of recent heroin initiates had used a pain reliever first, that only represents about 4% of all those pain reliever users that are transitioning to heroin. So you see reports in the media make it sound like everybody that has used a prescription pain reliever is now using heroin because they can't get a supply of the pills. That just isn't true. It is true that they are feeding the new initiation of heroin, and that's a grave concern to us. And the next slide indicates why that's a grave concern. The most serious consequence of opioid use is death. And this slide shows death rates for a couple of drugs. The orange line is the deaths per 100,000, or the number of deaths for prescription pain relievers, and it's up around 16,000 in 2013. Heroin had been very low and involved heroin deaths at about 2,000 for many years, but in the last several years, it's increased dramatically, particularly since 2010. It's gone up 172%, and that is just very, very frightening and something that we are trying to do something about here. And the yellow line is cocaine, deaths involving cocaine. Next slide. This slide looks into these numbers a bit more to show how the pattern of use has changed over the years. The blue bars are from 2000, and the red bars are from 2013. And what you notice is in every category, this is by race, ethnicity, and age, every category, deaths involving heroin, the rates of deaths involving heroin are up, but they're most dramatically up among young whites, and particularly young white males in suburban and more rural areas. So the use patterns are changing dramatically here, and that has significant importance to how we deal with the problem. Next slide. And this slide simply shows that it can be dealt with. The orange line on this chart is deaths due to HIV. And you can see the very sharp rise, peaking at about 16 deaths per 100,000 people back in the mid-90s. But about that time, there was the introduction of highly active antiretroviral therapy drugs, these cocktails of medications that have prolonged life for people infected with HIV. And there's a subsequent sharp drop, which has continued. But on the other hand, the yellow one shows drug-induced deaths, many of which involve opioids, have risen sharply. And we have a medication to deal with opioid substance use disorders. We have 3 of them, actually, methadone, buprenorphine, and Vivitrol, but they're sorely underutilized today. And that leads me to my last slide, which is treatment admissions due to opioids. And that's the red line for heroin. The black line is for the pain relievers. That was rising sharply in recent years, but has stabilized and maybe even dropped, where the red line is the heroin. They have surpassed marijuana admissions, which had long been the leading primary cause for treatment in the United States. And that's all I have.
Thank you so much, Dr. Zobeck. Next, we're going to hear from the Ocean County, New Jersey Prosecutor, Joseph Coronato. He graduated from Uppsala College in East Orange, New Jersey, and then received his law degree from North Carolina Central University Law School. In 1976, he was appointed Deputy Attorney General in New Jersey and assigned to the Criminal Justice Division. Served as an assistant prosecutor at the Atlantic County Prosecutor's Office and also served in private practice. In 2013, he was sworn in as prosecutor, the Chief Law Enforcement Officer in Ocean County, New Jersey. In response to rising overdose rates, Prosecutor Coronato has taken bold action, and we're very fortunate to have him here today to speak about his efforts.
Well, thank you very much. Let me tell you a little bit about Ocean County. We have a population, next slide please. We have a population of about 600,000. We sit on the coastline, so during the summer our population probably doubles to a little over a million people. Our mean income is approximately $89,000. Again, tourism is one of our big industries here in Ocean County. When I became prosecutor in 2013, I took a look at the overdose deaths in 2012, and there was 53. I guess in 2013, when I became prosecutor, probably within the first 2 weeks of becoming prosecutor, we had 8 overdose deaths in 7 days, all under the age of 28. I had one young girl in the town that was 18 years old who was doing 50 packs of heroin a day, 25 in the morning and 5 at night. It's when I knew that there was something as a dad that I had to do something about it. In 2014, we went down to 104 overdose deaths, and I think that has a lot to do with the fact that we instituted Naloxone, Narcan. I realized back in 2013 that we had to do something, and that seemed to be the area that we needed to. You'll see that so far this year we have 2015, we have 42 overdose deaths as of the end of May. I would say about 90% of our overdose deaths are based on opiate. Slide, please. Our strategic plan that we put in place here was education and prevention. We need to go into the school systems. We need to be embedded there. I meet every month with the superintendent of schools of our different districts. It's important that we weave ourselves into the educational community. I believe in strong law enforcement. We do strict liability, meaning holding people accountable for the drug dealers, are holding accountable for the overdose deaths. And then you have to have what I believe is a very strong Narcan, Naloxone program. And I think just the program itself, we need to break the cycle of addiction. That's important. I would say here in Ocean County that 80% of our crime arises out of drugs. Therefore, if we truly attack the drug problem, our crime rate will fall. Next slide, please. After I became a prosecutor, I took a look at the national or state legislation, and I saw that New Jersey was sitting in an opportune area in which we had passed many different laws that would allow the use of naloxone, and it was important that we implement same to get through the to actually turn down the overdose death. Next slide, please. Our Narcan program again started in 2014. It was implemented starting in April of 2014. You could see that in 2014 we had 129 deployments. So far this year, as of May, we've had 102 deployments. It's important to understand that Narcan, since it's, let me give you a little history. Since I am the chief enforcement officer for the county, I do lead all the police chiefs in the county, and I was able to implement naloxone in each of the towns. So every PD, every police department in Ocean County has naloxone. As a result of what happened here in Ocean County, the other 20 prosecutors in the state of New Jersey implemented similar programs, and I think New Jersey happens to be one of the few states in which it's really thrived now throughout law enforcement, and we have probably 80 to 85% of all law enforcement Narcan on the beats. I think it's important to understand that Narcan by itself is not going to solve the problem. We need legislation changes here in New Jersey. Unfortunately, heroin has always been, the gradation of the offense has always been based on weight. I think it has to be done by dosage, so I'm asking for law to be changed in this area. We do have voluntary PMP for doctors. I think that we need to have legislation so it'd be required to have PMP. I think that's important to fight this area. Next slide, please. What became important to me, I guess, was the fact that just spraying somebody and using naloxone was a temporary fix. I think that we need to institute a second program, and I think Narcan 2 is it. Again, we need to have law enforcement partnership with healthcare, develop strategy to combat the cycle of addiction. And I broke it down into 3 areas: the hospital, the detox facility, and the treatment options. I think that to implement the second half of Narcan is important. Otherwise, Narcan just is a temporary fix. Next slide, please. So what we do is, it's the way Naloxone is used. It's a spray. That means that when law enforcement uses it and it's deployed out in the field, that individual has to be brought back to the hospital. The patient is brought to the emergency room and is monitored, but emergency room treats it as a MASH unit, more or less, meaning that once that person is out of danger, life-threatening danger, it's not that person is kind of pushed off to the side. It's important for me that's to me, to have that happen is a lost opportunity. So it's important that we have an interventionist, a specialist, somebody who is going to approach that individual just before they walked into the light, they were at death's doorstep. We need to have somebody at the hospital, go to the hospital, at the hospital, that's going to intervene to try to convince that person that as a result of what just happened, that they need to get into a program. Then we need to get them into a detox facility, and it's important that we just not give that person a slip of paper to follow up, that person is physically brought to the detox facility right from the hospital. Therefore, I require the detox facility to actually pick up that patient. Again, that would be a lost opportunity to allow that addict to go back to its culture because, again, chances are they're not going to ever go into any kind of rehab facility. Next slide, please. When they go to a detox facility and they're brought there, they need to stay at that facility a minimum of 24 to 48 hours. There needs to be an assessment done of that individual. They need to take a look at that lifestyle, to see what type of individual they have, and to find out what options for that patient would be appropriate. And then they need to recommend treatment and a referral to a doctor. Next slide, please. The treatment options really amount to, what I found is that as much as I want to believe that inpatient treatment is the best way to treat a heroin addict, it's impractical. The cost. If we probably took an election here in Jersey and said, look, do we need more treatment facilities? They would say yes. But as a planning board attorney prior to becoming prosecutor, not in my neighborhood, and it's cost prohibitive. So you need medicated treatment to really solve the problem. It's broken down into 3 areas: methadone, Suboxone, and Vivitrol. It's important that these treatment options be pressed. My biggest problem here is that there doesn't seem to be best practices within the healthcare community for methadone, Suboxone, and Vivitrol. That's something that we need to drill down on. But it's important that when that individual leaves a detox facility, one of these options are given to them and that they're followed up on. It's important that what really is important here more than anything else is the fact is that the healthcare community treats these individuals as a disease, as a sickness, not as a second-class citizen. And as I drill down on the problem, it appears more and more that if we do not partner with healthcare, that we're never going to be able to solve the problem ourselves. Again, that's pretty much what we've done here in Ocean County. The second half Narcan has been implemented here. It's a struggle because, again, working with the hospitals, we need to treat that individual who's been brought into the hospital with Narcan so that they're just not released. They need to be somewhat medicated because if they're released straight from the hospital, chances are they're just going to go out and want to buy again and purchase. So again, how they're treated in the emergency room needs to be changed. We need to somewhat capture them from the emergency room and get them into a detox facility, and then we need to put up viable treatment options. And if we're able to do that, we may have a chance to solve the problem. Thank you.
Thank you so much. Now we're going to hear from Michael Morrissey, who's the district attorney in Norfolk County, Massachusetts. He was elected to that position in 2010. His office prosecutes more than 15,000 criminal complaints from 27 communities in 5 district courts and the Norfolk Superior Court. Since he became the DA, he's implemented substantial steps to improve school safety, curb drunk driving, and prevent substance use disorders, especially among young people. He has quintupled the number of Norfolk County communities with dedicated prescription drug collection containers, and he has produced a series of informational videos alternately targeted at parents and at teens. And for that, he earned Producer of the Year Award from Quincy Access Television in 2012. Has a JD from Suffolk Law School, Master's in Public Administration from Western New England College. And he was elected previously to the Massachusetts House of Representatives as a representative from Quincy. So we're very happy to have you with us today, Mr. Morrissey.
Thank you. Good afternoon. I'm Michael Morrissey, the Norfolk District Attorney, and I'm proud to serve as the Chief Law Enforcement Officer for 700,000 people in 28 communities in Massachusetts. And the leading cause of preventable deaths in my jurisdiction are opiate overdose and impaired driving, both often caused by substance abuse issues. The next slide, please. As you can see from the chart, the number of opiate overdose deaths is on the rise. From 2010 to 2014, the number of overdose deaths has almost doubled. For this year, we are on pace to hit over 120 deaths. In fact, I think we're at 65 as we speak here today, and we're not even halfway through the calendar year. I am positive that these numbers would be much greater if we in Norfolk County hadn't undertaken some of the important initiatives which I know are making a difference in saving lives. The next slide, please. We're proud to have been one of the original Hal Rogers Category 3 grant recipients. We were funded to develop a multidisciplinary initiative to prevent overdose deaths. And my office, along with the Stoughton Police Department, presented naloxone training information at the National Prescription Drug Abuse Summit in Atlanta this past April. But I want to be clear, you don't need to obtain federal funding to do this important work. In fact, we paid for a number of these projects with drug forfeiture money obtained from successful drug prosecutions in my office, and many of these trainings and initiatives were all performed by volunteer labor. Now, as the district attorney, I know we can't arrest our way out of these problems, so I'm going to spend the next few minutes speaking to you about what my office has done in Norfolk County to save lives. The next slide, please. My own hometown in Quincy, Massachusetts has had tremendous success with police-administered naloxone through a state pilot program and are nationally recognized for their work. But this funding source was not available to other communities in Norfolk County. It was clear early on that the administration of naloxone was saving lives. We became creative and figured a way to train and equip all 28 police and fire departments and their vehicles in Norfolk County with life-saving naloxone. I even have hired a retired pharmacist to work part-time on the project and to help out. The next slide, please. We conducted training for all Norfolk County police and fire personnel in the administration of training, a so-called train the trainer. The naloxone is easy to use and absolutely saves lives. If you go to my webpage at norfolkda.com, you'll see the training program on naloxone, what is needed to equip your community with this life-saving drug. The information can be downloaded. It can even be changed to edit as you see fit, and it's a good way to get it out to all the departments or people who just want to learn how to use it. The next slide, please. By way of example, the town of Sharon is an affluent community in Norfolk County with a population of 17,612 people. In 10 months, the Sharon police administered naloxone 11 times and saved 10 lives. The next slide, please. One of my favorite communities, by contrast, is Holbrook, a former mill community, which is a population of 10,791 people that's also located near the city of Brockton. They had 23 naloxone saves in an 8-month period. But my own hometown has over 400 saves in 3 years. More than they tell me, the local police tell me, half of which would have been deaths if it weren't for naloxone. We recognize that naloxone is not going to curb the prescription drug problem, but it certainly saves lives and gives people struggling with addiction another opportunity to get into treatment. Next slide, please. The slide is a map of these 28 communities in Norfolk County, and we partnered with Covanta, a national waste disposal company, who had an existing drug take-back program. We purchased drug take-back boxes that are housed in 26 of 28 police stations in Norfolk County. 2 stations that weren't large enough to house them in the lobby, and they have to be secured because of the value of the drugs that are often dumped there. The next slide, please. 24 hours a day, 7 days a week, residents of Norfolk County can drop unwanted or unused prescription drugs off at our drug take-back boxes without any questions being asked. This has proved to be an effective and efficient in getting unwanted or unused pain medication out of our medicine cabinets and off the street. Remember, the studies show that up to 70% of our young children get their first experience with pain medication from someone else's medicine cabinet. The contact information for the boxes are listed on the slide, or you can contact the office. The reality is you don't have to wait for the DEA to have their take-back days. The next slide, please. Just last week, I went to a meeting in Franklin, Massachusetts, which has a take-back box in their police lobby. For over 2 years, the police department has destroyed almost 3,000 pounds of unwanted and unused prescription drugs from the take-back boxes. In fact, the only complaint I'm receiving about the take-back program is that the police say they have to empty them at least once a week in most cases, and sometimes more, which I know is a good problem to have. Next slide, please. My office has also designed flyers that are distributed at local pharmacies and medicine bags, which educate consumers on how to safely store and dispose of their unwanted or unused prescriptions. Education has been clearly lacking on the prescription drug abuse, and the pharmacies have been most helpful in that regard. The next slide. Well, we have found that the most successful work often gets done when you bring multidisciplinary groups together to address the issues. My office has partners with state and community leaders to make changes. The next slide. If you could go back one slide, I'd appreciate that. The slide is all the police chiefs and fire chiefs are at Gillette Stadium, which, by the way, is the home of the world champion Patriots, but we won't go into that today. But I work hand in hand.
Thank you, Mr. Morrissey, for underscoring that important point.
Exactly. So I work hand in hand on a daily basis with the local police and fire chiefs in the county, and our communication makes a difference and helps us save lives. My office and local law enforcement meet on a bi-monthly basis for overdose review meetings. Each overdose death is reviewed for alarming trends and is run through the prescription drug monitoring program. Any concerns regarding the dispensing of medication are often reported to the boards of registration of medicine or pharmacy. And to date, we have referred over 30 doctors to the Board of Registration of Medicine. And I'm not suggesting that they've done anything criminally wrong, but I think that the standards of practice should be reviewed by their own peers. The next slide, please. Community coalition members. We have assisted in forming community coalitions in a number of Norfolk County communities that address wide-ranging unique drug issues in their own community. The next slide, please. When we started, there were 7 community coalitions when I took office. The next slide, please. And now we're closing in on 20 community coalitions established in the county. And I'm proud to say that the formation of Franklin's recent community coalition will make 20 in the meeting at the end of the month for their first meeting. But they have been active in the fight of both arresting and taking back, so it's just one more step in the development. So to continue to develop programs and educate the communities, they have seen the value, as the community coalitions have really provided an awesome resource to get the word out. The next slide, please. But we didn't want to leave the community coalitions alone. We also developed a safe prescribing working group, which comprises a number of disciplines in the county, including the police and fire personnel, school administrators, and community members. We created smaller subgroups comprised of doctors, nurses, and members of local healthcare organizations to help to address the prescribing issues and trends. The photo shows the Safe Prescribing Group is collaborating to change how prescriptions are dispensed and doctors are monitored. The next slide, please. Is my contact information. If you're interested in any information or any of the initiatives the office has undertaken, please visit the website or call us directly. The information is there. I hope you will incorporate some of these initiatives in your own community as well. If you have any idea that's working, please let us know as well.
Thank you so much, Mr. Morrissey. We're going to open the line for questions now.
All right, thank you, Deputy Director. We will now go to questions and answers. To alert us that you have a question, please press *1 on your phone, and your line will be opened by me, the moderator, in the order it was received. Please make sure your phone is not on mute when your name is announced by me, the moderator, to ask a question. Finally, please then state your name and organization before each question. And again, dialing *1 on your phone will place you into the question queue. All right, looks like we do have a question from the audience. Let's go to the line of Peter Hamburger. Your line is open.
Hi, this is Peter Hamburger. I'm an intern at the National Juvenile Justice Prosecution Center in Washington, D.C. And it looks like a lot of the education and prevention needs to start, obviously, with school-aged kids. What type of work, if any, are communities doing with school boards or in school districts to help get the message to as wide an audience as possible about opiate abuse?
Well, so this is Joe Coronato. The first thing I did is we all assistant prosecutors, hands on deck. We go back to school night in September. So every high school and every middle school, we're there for 5 minutes back to school night to talk to the parents about the drug problem. We've put together forums that we've had. We just did a forum where we had 1,400 people. We did a forum last year. We had 5,000 people. We do a series of forums throughout the county. I have canine units going into the schools to, again, not necessarily to arrest anybody, but to walk through the schools to see that there's no drugs in the lockers, in the bathrooms, or out in the parking lot in cars. We also have videos that we've put together similar to what they've done up in Massachusetts. That it's important for us to partnership. And I've also put stickers in each of the high school lockers and middle school lockers. They have barcodes, and they can download our mobile app that we have for our phones that tells them about our videos, tells them if they want to give us a hotline tip that can help them with any of the issues. So those are some of the things that we've done here in Ocean County.
And it's Michael Morrissey. I concur that the idea of having we have a school partnership, and again, we focus on the problems as we see it, and so we often do a lot of trainings, particularly with school nurses, administrators, and security personnel in the schools to help them identify some of the problems and some of the solutions to those problems, which often are related to drug and opiate use. But we also rely heavily upon the community coalitions, because when you get people in the community that are interested, and we try to include the schools as a key component of those community coalitions, then it helps spread the word in education, and it starts to filter down even into the lower grades. So that has been successful as well.
Great. Thank you very much.
And this is Mary Lou Leary from ONDCP. We have a grant program called Drug-Free Community Support, and we fund about 680 community-based coalitions around the country to do substance use disorder prevention with young people. So if you want to work with one of those local community coalitions or start one in your own community, go to the ONDCP website and look under Drug-Free Community Support.
All right, so let's go to our next caller, the line of Joyce Roldan. Your line is open.
Hi, how are you? My name is Joyce Roldan. I'm Assistant State's Attorney here in Frederick County, Maryland. I did have a question for the panel regarding drug treatment court and what your jurisdiction, their experience with utilizing drug treatment court as a way to respond to the heroin epidemic, as you all stated.
This is Michael Botticelli. So why don't I start from a national perspective, and certainly other folks are feel free to chime in. You know, one of the things that I think every panelist has mentioned is the need to divert people away from incarceration who have significant substance use disorders. And drug treatment courts are highly effective and have been highly evaluated in terms of providing that level of support and training. I think we have over 1,200 drug courts in the United States now. I stand corrected, over 2,000 drug courts in the United States, serving a significant number of people. I will say that one of the opportunities that we see, in addition to drug courts, is really looking at front-end diversion. So from a trial standpoint, how can we divert people into treatment so they don't quite honestly have a lifelong criminal record as a result of their substance use disorder. So we, and I know many folks at the local level, are focusing on that front-end pretrial diversion as well as a whole host of other interventions.
Here, this is Joe Coronato from Ocean County. We do have a drug court here in Ocean County, and very, very successful. I will say this, the drug court does not allow for medicated treatment, so meaning that it's abstinence. I do agree with the director that the future is diverting from the system itself. I think right now what drug court does is divert you through the system. I think the future is to divert from the system. And I do think that that's where medicated treatment can come into, so that if you have a small possession case, you keep them out of the system and you get them the help that they need. And we're going to try to implement that here in Ocean County.
And it's Michael Morrissey. I would agree with two speakers, and the only thing I would add is we do have a drug court. It has success. Not everybody can participate in it, but one of the things that I've noticed is that it tends to be much more successful depending on who the judge is sitting and how committed they are to the program. And also they have the appropriate resources in place to handle housing, employment, treatment, and other aspects that are necessary to support the individual going through the drug court, which can take a year and a half in some cases.
And this is Mary Lou Leary from ONDCP. The scientific evidence is very strong that medication-assisted treatment is much more effective than a treatment protocol that does not employ medication. It's one important component. And so going forward, we worked with SAMHSA, Substance Abuse and Mental Health Services Administration, and with the Department of Justice, their Bureau of Justice Assistance, on the language that describes the eligibility requirements for their federal grant dollars to fund drug courts. And drug courts that do not allow medication-assisted treatment will not be eligible for federal grant dollars. So you cannot have a blanket prohibition on medication-assisted treatment if you want to get federal grant dollars from those agencies.
Thank you.
All right, and we have no more questions on the queue at this time.
We have one question here from Kay Cohen.
Hi, this is Kay Shepard from NDAA, the executive director there, and I really appreciate Mike and Joe doing this for our members. One of the questions that I get a lot when we have discussions of this among prosecutors within NDAA is concerns about what do you do or can you go against dealers. So, Joe, your example of the 18-year-old who was using 25 packets every morning and 25 packets every evening, a lot of prosecutors say, you know, they're less interested in her, frankly, and more interested in who's selling it to her. But what is the balance with that, with many of the Good Samaritan laws? Because that is the one area of pushback that I hear from prosecutors who feel that they're really less concerned about possession and more concerned about getting to dealers. So do you have any experience with that or examples that you could help? How do you deal with that argument or that concern?
Well, I mean, first off, you know, it's all about saving a life. So what we were concerned about is not the 18-year-old dying. I will say this: we have a strict liability, and we have strict liability here where we've got 19 cases. Of those 19 cases that we've done the strict liability on, 11 have pled guilty. And what that means is that we track back who the ultimate dealer was, and we hold that dealer accountable. What normally happens is that we ascertain, usually by getting into the cell phone or different other investigative methods, where the drugs came from. We make a buy. We usually end up at some point in time being able to charge the drug dealer itself. And the reason why that works as so far as law enforcement is concerned is because at that point they're checkmated. As I said, they not only have the distribution charge, but now they have the homicide charge. And as a result, it turns into what we call a strict liability case, and we seem to be successful with that. I think the point is that that's why I'm embedded in trying to break the cycle of addiction, because we're not really looking to jail, or it's impractical to say that you're going to jail addicts. And what you're really looking to do is to save their life and to break that cycle of addiction. So from my standpoint, you can do both and be successful at both.
And I concur. The first thing we have to be is concerned about saving human life, and particularly, as I guess I get older, and we look in the late 60s and early 70s, and society used to look at people who were using heroin as junkies and as a back alley problem. Today, it's really good kids from good families, and so trying to deal with those people and get them help is a primary obligation, but also focusing some attention, as Joe suggested, to those people who are truly distributing and poisoning our young people. We employ some of the same things. If someone is to die, although I think our laws are a little different in Massachusetts, it's very hard to bring a manslaughter case against someone unless they had the willful, wanton, reckless aspect of their own knowledge of selling bad heroin. So there have been some cases that have been successfully tried by different counties, but they're very hard to try. And Massachusetts is soon to be undertaking a debate over mandatory minimums, which a lot of the sentencing structure is based upon the weight of the powder that they would find as to the term of years. But we also focus on trying to get people help where possible. And in the case of a death, if the state police go out and investigate with the local police, there's no expectation of privacy on a phone, so we try to download phones. But ironically, as technology has moved on, it gets harder and harder to get access to encrypted phones. And so we do start and have had a number of investigations that have been built off that, or interviews that we have taken at the scene of an unattended death, which is usually by heroin or opiate. So we spend a lot of time and resources trying to get that next layer and to get to the person who is really distributing the drugs.
Thank you. Do we have any other questions on the line?
There are no questions at this time.
Okay, thank you. And I want to thank especially Director Botticelli, Dr. Zobeck, Prosecutor Coronato, and DA Morrissey, and Kay Chopwood-Cohen for being with us today. And thanks to each of you for your interest in this issue. I hope this was helpful to all of you, and I hope that you've learned something that you can use to address this problem in your own jurisdiction. Thanks again for joining us today. Goodbye.